Hello, everybody, and welcome to another honest conversation for the HSJ Patient Safety Congress. I'm Sean Linton, health editor at the Sunday Times and chair of this year's Patient Safety Congress, which is in its 16th year. Key to this year's event is, as we say, honest conversations, being realistic about the challenges that you all face and the system faces at the moment. And joining me today for this honest conversation is Jules Storr. She's an independent global health consultant and former past president of the Infection Prevention Society, and she's going to be joining us in Manchester doing a session on infection prevention and the psychosocial elements to that. And she's joined me today to have a bit of an honest conversation about that exact topic. Hi, Jules, how are you?
I'm good, Sean. Good to see you.
Well, thanks for joining us. So let's just dive straight into this. I want to ask you that clearly we've just come out of a global pandemic where infection prevention, was making front page news almost every day. And, I remember infection prevention being the sort of nerdy group of clinicians in the corner telling everybody else what to do. But then all of a sudden you were thrust into the front and center. But it wasn't a very particularly easy time for anyone in infection prevention, and a lot of bad things perhaps happened, didn't it? And I would just wonder if I could ask you as an opening question, how bad did things get during the pandemic in terms of infection prevention? Did we make a lot of mistakes there?
Wow, where to start with that? Clearly, one of the things that we're going to be focusing on in Manchester is that very issue of infection prevention and control decision making. And that's not just by infection preventionists like myself, but the whole array of people who had to make some really hard decisions, often end of life decisions around who could have physical contact with loved ones. And I really like the theme of this year's conference around the honest conversations. And I think that to have those honest conversations, not just infection prevention people who write the policies talking to themselves, but that multidisciplinary feel. So I'm hoping that we can really try and answer some of the issues that emerged from the pandemic and not forget them. I think often when we have those horrendous catastrophic events like we did from 2020, there's a temptation to want to move on and forget some of the hard things. And I really welcome HSJ not doing that and trying to bring together myself, some of the colleagues from patient safety, and also some people who were affected by some of those decisions that were made. And that's from the patient and carer perspective. But we also need to be talking to the nurses and the doctors as well. And I think what happened during the times of COVID, when in the eye of the storm, some really, really tough decisions had to be made, and they had to be made quickly. And I think, we can all understand those decisions and the implications they had around restricting visitors in hospitals, in health, social care, nursing homes, long-term care. I think what then happened afterwards, like weeks and months passed, and I was still being contacted by colleagues, by members of the public who were saying, help, something's not quite right here. I have been married to my husband for 50 years and he's dying in a care home and I can't go and see him and touch him. And I think, Sean, one of the things that I did, which sounds really banal actually, but I just issued a tweet, or as it was then called, and said, look, hearing some strange stuff going on around infection prevention being used as this blunt instrument in the most vulnerable times of people's lives. Anybody else want to come together with me and try and do something about this so that we can use infection prevention and control, IPC as it's abbreviated, as some sort of enabler of safe interactions. And we got this huge response, and many people may know that the Nursing Times stepped up and they helped us write this open letter where we laid out some potential solutions, so that all we wanted to do at that time was to try and make sure that in particularly vulnerable times, often end of life, we could make sure IPC could be used to connect people in the real world and touch each other and hold hands and have that physical contact. And yeah, the rest is history. We published the letter. The Nursing Times stepped up. It was an open letter. It was then picked up by some of the civil society groups to empower them to talk to their governments and their accreditation bodies and their regulatory bodies. It was picked up in the US. It was picked up by groups lobbying for like people with dementia to have access to loved ones. So it was what we were trying to do was say, look, infection prevention is about germs, bugs. It's about stopping them from spreading. But we really need to look at the unintended consequences of some of the things we're doing to stop those germs from spreading. And 2-3 years later now, I really think is a great time to have that conversation about, would we do the same thing again? If we had another outbreak of a different bug, how can we make sure that we use infection prevention as a force for good, if I can use that that phrase?
Are you worried that people will still sort of instinctively knee-jerk reaction pull the lever to just stop visiting and wrap their patients almost in a sealed room and withdraw a lot of that family connection in the event of, let's say, a flu outbreak this winter, or a norovirus, which is a common complaint in hospitals around the winter time? Is there a danger that people are going to think, well, everything became that normal during the pandemic to just restrict visiting, and we might go back that way?
Yeah, I think I am still worried about that. I think one of the things we raised in that letter, that open letter, was that issue of what's called de-implementation, and I think some of that 3 years later still lingers. I still am contacted by people who are telling me that the restrictions are still in place to some degree, and often it's that issue of often the guidance wasn't wrong, and it wasn't uncompassionate. The guidance was stating that you should be proportionate. You can exercise discretion. Phrases like at end of life you can exercise discretion, and I really want to see frontline health workers supported to make those decisions so that they can apply that discretion in the right way, because it's often just not fair for a nurse on a ward to be told it's at your discretion. The default is to err on the side of caution, particularly if you're not perhaps a senior or aware of your own sort of power. And
But that can have really serious consequences for families and patients, can't it? And that's the issue there. But then there's the other side of the coin that I wanted to ask you about, which is patients who are vulnerable to viruses and infection and things like that. And you've got to balance those two elements. How do staff approach that? How should they be approaching those kinds of decisions?
I think, obviously there's lots of different ways of supporting staff, and having good, clear, unambiguous guidance is one part of it. Guidance that's consistent across all settings, and I think that sometimes was an issue, that you'd have one area public health guys saying one thing, a different country just a few miles, even Scotland, England, different approaches. Training, of course, is one element as well, and infection prevention practitioners themselves having the opportunity to support people in their risk communication, the decision making as well, because there were many stories around where discretion was very thorny. So I've heard people say that, and quite senior colleagues have mentioned things like their relative, their loved one, because this has affected personally probably everybody in that audience that we're going to have in Manchester. So I don't underestimate, this is a really heartbreaking situation for many people and traumatic. But a colleague told me not long ago, loved one was dying in hospital, but she was told, you cannot see mum because she's not actively dying. So it's those sort of things, it's like end of life was taken to mean hours, whereas actually the guidance stated end of life could be up to a year, and it's like, how can we support people to be empathetic and compassionate but safe as well? Because I'm not for 1 minute saying that we throw IPC out of the window in these situations, not at all. But some of the work we did with one of the colleagues, Sheila, who will be speaking in Manchester, we worked with one of those groups up in Scotland to develop like very visual flow diagrams of entry into a care home. Every single step you take, little illustrations from going through the front door to sitting down with your relative. And I think we could do the same kind of thing in hospitals, and some hospitals may have done that. We know that there was variability. We know that some hospitals, nurses, docs, multidisciplinary teams did every single thing they could to make sure that people could see loved ones at those times. And we've got to learn from those where it worked, but try and shift, those where that didn't happen, much more towards that kind of approach, because it can be done and you can enable safe care.
Yeah, it's a big topic. It's a big topic, and you're gonna be exploring this at the Patient Safety Congress, and I think we're going to be looking forward to hearing a lot from the panel and your thoughts on all of this. But clearly, the theme for the Congress this year is honest conversations of the challenges that people are facing. Infection prevention is one, but I'm interested, as you sit at the moment overseeing sort of the whole system from a global perspective, what's the where do you think the big challenges are for patient safety generally at the moment?
I think in many countries we know that there are not enough health workers, and I think that's probably a massive issue that affects safety of patients. It affects the safety of the health workforce itself, and we can't ignore that, Sean. So, and I think that there are solutions that will keep people safe from all sorts of risks, but there's some fundamental sort of health system issues that need to be addressed, and obviously, globally, there's a big driver from, I do a lot of work with World Health Organization, as you know. There's a huge amount of work to try and address some of those issues. The new chief nurse at World Health Organization has that high on her agenda, because without a skilled health workforce, a lot of what I'm talking about is very, wishful thinking. So yeah, there's some hard things, but I don't think that shouldn't stop us right now having honest conversations about these issues as well. Like, how do we deal with this, even in the UK, where we have problems with retention and recruitment of staff? So yeah, that's the situation. But how do we try to make sure that 80-year-old lady can see husband when she's at end of life? It has to be possible.
And in Manchester, this in the next month, Julius, what are you looking forward to seeing at the Congress? What do you think is valuable about the event?
I think bringing some of the people who have been implementing and researching and testing out ways to improve the safety of healthcare into the same room can, I know from even my days back in IPS, the value of conferences, although it can seem that you've distanced yourself from reality. Often they can act as a little test tube of energy and motivation that actually does make a difference when you go back to work, because you've got new ideas, you've got motivation, you've got new thinking, and I'm certainly looking forward to some new ideas myself, just looking at the programme.
Well, I'm hoping that's what we're able to give our audience next month, and I'm certainly going to be making a note to try and reach your session as well, Jules, and really grateful for you talking to us this morning. Thank you very much for your time.
Thanks a lot, Sean. Look forward to the conference.
Thanks.